And let's please give our attention to Dr. Mary Schmidt, and she is going to introduce herself. She's from the CMT clinic at the University of Michigan and is here to talk about exercise. Thank you, Dr. Schmidt.
Thank you. Can you guys hear me okay if I'm like standing like this?
No.
Yeah, I didn't think so. Okay. Is this better? Thank you. I tend to mumble and talk too fast, and so I am very cognizant of trying to speak a little bit slower right now. Okay, so I am Mary Schmidt. I am a physician at the University of Michigan at our CMT Center of Excellence. I've been there for about 8 years now. I think we have about 250 patients, so lots of repetition for me, lots of experience with CMT. I am a physiatrist by training. I was going to give you a nice introduction to PM&R, but we just got that at the last hour. Dr. Guppin did a really nice job. So I'm a physician that did a residency in a field of medicine called physical medicine rehabilitation. So that kind of focuses on neuromusculoskeletal system in terms of function, mobility, those kinds of things. So that could be somebody who's had a stroke, or maybe a sports injury. We do inpatient and outpatient, all rehab focused. In the CMT clinic itself, I handle most of the rehabilitation aspect of things. So I will put in orders for orthotics, DME, like walkers, wheelchairs, all of the insurance requirements of documentation that comes along with it, and kind of helping patients navigate those things. And then physical therapy is another big thing I order, and going along with that is exercise. So we're going to focus mostly on exercise today. Happy to help discuss any other topics that I just listed, but we're not going to go down that route at the moment. Okay, so I wanted to start by just kind of presenting a little bit of broad overview of what research has been done on exercise in CMT. Not a ton of studies. And the studies that have been done tend to not have a very big sample size. So prospective studies, meaning like enrolling someone in the treatment and then watching them progress through the treatment, tend to be a little smaller. They tend to be a little more time-consuming, it's expensive, harder to recruit patients for. In CMT specifically, in exercise, the sample sizes were maybe like 8 to 50 or so people. They also looked at very varying exercise protocols. So it could have been like a treadmill training, doing more aerobic activity, or like a strength training program. Also a lot of variability in how long they followed patients for. There are a couple studies that have done a retrospective review, meaning like they went through charts and tried to pull out data from what was written in the patient's clinic notes. And that was more of a passive modality where you kind of observe patients documenting their exercise habits and their strength. It's hard to draw a lot of conclusions from that because, if people have more strength, maybe they're just naturally able to exercise more, or is it, cause or effect? So kind of keeping that in mind, what kind of conclusions can we draw from the limited research that we have? Okay, so from the studies that have been done, exercise has been shown to be beneficial in CMT. One of the big caveats is that sustainability is very important. So one of the studies I mentioned, I think they followed patients for like 12 weeks, and then they followed up in a year. And at that year point, if people hadn't been continuing the exercise program, they had lost all of the gains that they had made while in the study. So sustainability is really important. It has to be tailored to the individual, and that's something I'm just going to keep emphasizing as we talk. Exercise is for you, and it should be driven by you, and so it should be a positive thing. You feel motivated to do it, get something out of it, and of course, we're all individuals. All of those factors are going to need to be individualized. Adapting to barriers is really important when we think about exercise too, and that could be financial barriers, physical barriers, mental barriers. Personally, I think the mental barrier is one of the big aspects I see for people with CMT and just the general population. Asking people to exercise feels like a big ask. Okay, so cannot emphasize enough. When we talk about exercise, we want to just really emphasize we want you to move in ways that are working for you, things that are working for you. I'm going to throw out some ideas here, give you some direction, but Please tailor it to what interests you. Okay, so types of exercise, just kind of giving like some practical ideas of what we could be doing. Aerobic exercise is activity that sustains your heart rate up. And so that's kind of the traditional exercise. Maybe you think about like biking, running, swimming, dancing, like any activity that's going to get your heart rate up. The American Heart Association recommends 150 minutes of aerobic exercise every week, which when you think about it being 150 minutes, that might sound really daunting and sound like a lot of time, but that could be 30 minutes 5 days a week. And it could be 30 minutes total. It could be like 10-minute, 3 10-minute intervals in the day, walking the dog around the block, things like that. The way to kind of just practical advice when you're thinking about a moderate activity level is to use the talk test. So if you get your heart rate up enough, you should feel a little more short of breath, feel like you're getting a little warmer. You should be able to still talk pretty easily, but if you wanted to like sing, it might be a little challenging. And then vigorous aerobic activity, it's going to get you to the point where it will be a little more difficult to even talk. And then one big thing the American Heart Association recommends is spreading this out throughout the week. So doing one big 150-minute session of exercise in the week is not really the same amount of benefit as spreading out your mobility throughout the week. Okay. They recommend strength training as well, 2 days a week, which could be using like a weight, free weights, resistance bands, but even using like our limbs against gravity is a good way to build some strength training, and we're going to talk a lot about that. And then I just wanted to talk about other ways of moving, like stretching and getting joint mobility. This is good for cross training. If you have a goal, you want to walk a certain distance, run a certain distance, whatever. Doing some stretching and mobility are really important to help get you there. I think they're a little bit easier to incorporate throughout the day since it's a little more passive, something you could be doing when you're like sitting at the desk, watching TV. Yoga and Pilates are also really great ways of stretching, working on joint mobility. They tend to incorporate movements that have a little bit of strength building aspect to them, so more like core and hip, which we're going to talk about at length today. So, where do we go from here? Let's talk about the exercises I think about with CMT and where I kind of want to send you off. So, a lot of people, formal balance exercises, when I write a prescription and send someone to physical therapy for their balance, the kind of traditional methods that might be used are not the best for people with CMT. And so often I will tell them in the clinic, like, look, I'm going to send you for this, but your PT may or may not be familiar with CMT. I don't want to leave you frustrated because the exercises they're giving you are way too hard, way too challenging. So I think about things like trying to walk in tandem, like this tape in front of me, like trying to walk the line there, balancing on one leg, like the boards that kind of throw off your balance. Those are really hard for someone with CMT, and the last thing we want to be doing is sending you to a program that makes you feel discouraged. So we're going to talk about some other ways to work around that aspect of things to build our balance. I really like to focus more on your core, your hip girdle, and kind of the knee area to build proximal muscle strength, and that will help your balance. Things like ankle range of motion are also really important. If you have really tight heel cords, that's going to impact the whole chain of your leg as you're walking, and so sometimes doing like some stretching or range of motion to get ankle motion back can be really helpful in CMT. And then we often don't think about our upper body helping us with balance, but as we walk, we swing our arms, and so having good upper back and arm strength can really help maintain your balance and upright posture. So, CMT, we think about ankle muscles, foot muscles, but you all have a physiatrist standing in front of you today, and so I am going to talk about the gluteus medius muscle. This is like the physiatry goldmine. All roads lead to the glute med in my world. So this is a muscle in our kind of butt area that is sitting deep underneath the glute maximus. So we often think about the glutes, we think about the big gluteus maximus muscle. That's a big hip extender. But our glute medius muscle is also this little workhorse that gets overlooked and ignored that's extremely important for maintaining upright posture and balance. So there is tons of research looking at glute medius and fall risk. So looking at hip fractures, geriatric patients, non-geriatric patients, checking people's balance. I have a colleague that has done extensive fall risk research, and everything leads back to the gluteus medius strength. So this muscle is in kind of the, like I said, the buttock area. It's not, I think about like your back pocket. That's not fully there, but it's kind of off to the side. Like if you were reaching to get to your back pocket, it's the first place you'd land. This muscle stabilizes the pelvis as we're walking. So as you go to pick one foot to advance it forward, the opposite standing glute med will fire and activate to stabilize the leg that's standing. You think about like if you fall, if you trip, you need that single leg stance. The leg that's going to try to catch your balance needs to really like quick activate and fire. And so that's where that glute medius weakness. If it can't catch you, then you're going to fall. Like I said, the glute medius is we also emphasize a lot in PM&R relates to hip pathology, hip pain. Often those rehab protocols have to do with hip girdle strengthening, low back issues, on and on and on. My spastic CP patients. So let's talk about strengthening that muscle. So I have both standing, sitting, and laying flat ideas for how to strengthen the glute medius. What they're doing is going in this motion called abduction, so moving the leg away from the center of the body. So this gentleman is using a chair to balance himself, and then he's lifting his leg up off to the side. The photo below with the TheraBand is just adding a little bit of resistance. He has it tied to his other leg. You could tie it to like a pole or something more sturdy, just if you feel like you need a little bit of resistance, but certainly can activate the glute med by just lifting it against gravity. In the seated position, this gentleman's doing almost like a clamshell, like his knee is leading off to the side and then coming back in. And then when laying flat in like a bed, just an abduction away from the body. The thing I really want to emphasize is that you can cheat well to get this motion without actually activating the muscle we're talking about. So if you're doing these exercises, you really need to be feeling that area of the glute med to make sure it is firing while you're moving. Couple more ideas. This woman's side lying, and then the other photo is clamshells, which is a pretty common like physical therapy exercise I'm sure many of you are familiar with. These are two areas where people can cheat really easily to get the motion without actually activating the muscle itself. And so you just want to make sure your hip, your trunk, and your hip and leg should all be in one line. You should not be falling like forward or backwards to get that glute activated. If the glute is really weak, you may not get much motion in these directions, but you can still activate that muscle. And over time, trying to activate that muscle, build the strength, it'll get easier. The next muscle I want to talk about are our hip flexors. They, along with the glutes, are super important for a lot of day-to-day tasks. Things like getting out of a chair, going up and down stairs, getting off the ground. They are considered part of your core. Our hip flexors connect to the front of our hips and then into the low back area. And so when they're weak or tight, they often contribute to mechanical low back pain, which I feel like I see a fair amount in my CMT patients. So to strengthen our hip flexors, just simply doing the motion in a seated position or a standing position to get that hip flexion. The nice thing about the standing position is that this gentleman, The leg that is keeping contact with the ground, actually that glute med has to fire at the same time, and so it's a good way to kind of mix in both muscles. And then if we want to advance our hip flexor strengthening, things like dead bugs. The photo at the top, the gentleman's laying in like a tabletop position, we call it. Just that position is requiring use of your hip flexors. Don't need to progress it any further than just that to get some strength training. If you wanted to, though, you could progress it to what he's doing on the bottom is a dead bug, so that the moving leg away from the body and the moving arm are opposite. Because you get this kind of opposite direction throughout the body, that also helps with like our obliques and core muscles. Can also do a dead bug from a seated position, which is what the photo on the right-hand side is showing us. If the hip flexors are tight, I just added in some ideas for stretching them. So on the bottom, that gentleman, the leg that is, so he's got one leg bent, and then the right leg is away from him. The leg that is away from him is the one that's getting the hip flexor stretch. What you want to do is just kind of gently lean in and kind of lean back, and you'll feel the hip flexor stretch. The woman above him is doing the same stretch on a chair. Personally, I feel like it's a little difficult. Like the base of a chair is not that wide. I prefer like a bed or a couch. I just feel like you get a lot more stability. The other photo laying on the bed table is just showing you a different way of doing it. Could easily do it on like a bed or a couch. The leg that is dangling is gravity is pulling that leg down, and as a result, you get a stretch in the hip flexor area. If you pull the opposite leg up, like he's doing in that middle photo, that also is a good way to get the hip flexor stretched. Okay. So I do want to talk a little bit about ankles because we are at a CMT summit. Just to give you some orientation, the ranges of motion we're talking about on the ankle are dorsiflexion, meaning the foot is coming towards you, plantar flexion, the foot is going away from you. I most often see plantar flexion contractures in my CMT patients. And so like I said earlier, if you're tight in the ankles, that's going to affect the whole chain of how we're walking. If I go up on my tippy toes right now, my knees are going to passively extend and kind of lock out. And if I walked like that, I actually wouldn't use much of my glute med muscle. And so that's a way a lot of people get by with a lot of gluteal medius weakness, or either by accident or, just kind of passively with their gait mechanics. They haven't really used that muscle much, so it's gotten weak over time. So I do want to proceed with caution when we talk about ankle strengthening. I was a little hesitant to even bring it up because I know, like, in the therapy world, I put this, I call it neuromuscular precautions. So when I put in a PT script for my CMT patients, muscular dystrophy, ALS, I always throw in this little verbiage dot phrase that I call neuromuscular precautions. And that is, we want to avoid overexerting muscles that we know are being impacted by the neuromuscular disease. So the concern is if you are working a muscle that is affected by your neuromuscular disease to the point of fatigue, you could be potentially damaging it. And so when our muscles start to feel tired and when we exercise, sometimes we are intentionally inducing fatigue. So if I do like a bicep curl with a heavy weight, I am intentionally causing micro tears to the muscle itself. And then the body will repair those tears. It'll send more blood supply, more nutrients, and the muscle will grow bigger. And in that way, I will be able to lift more weight easier in the future. However, if you get, neuromuscular disease, the question is, can the body repair the muscle that's been damaged from the exercise? And if not, if we are over-exercising the muscle, are we potentially making weakness worse? I hope that makes sense. So the precaution I always write on my note, and I like to tell patients this too, because it's like, when you're out there in the world, you're going to have to decide how you feel. You're going to have to monitor how things are going. We don't want you to feel weaker, tired, pain, right during the exercise or even afterwards. Every once in a while, patients will say, I went to a full session of PT and I come home and then I'm just exhausted. I have to go to sleep. And it's like, okay, well, what is that really helpful if we've overexerted you, kind of took in your whole energy reserve for the day and exhausted you? Same thing for the ankle muscles. But I do get this question a lot in clinic, and so I just wanted to put some ideas about strengthening the ankle muscles. I would say if you are able to lift the ankles against gravity, I would be very cautious about trying to do exercises like this. If you're not able to lift against gravity, I would not worry about doing these types of exercises. However, I do want to talk about stretching because everyone can benefit from some ankle stretching. So two muscles we want to talk about are the gastrocnemius muscle and the soleus muscle. So the gastrocnemius muscle is that big calf muscle in the back of our leg we're all familiar with. It does that plantar flexion motion. I am showing you this photo because the gastrocnemius connects above the knee. The soleus muscle sits underneath the gastrocnemius, also does plantar flexion. It does not cross the knee joint. And I am telling you this because we want to intentionally stretch both of these muscles. And so if we do not bend our knee, then we will not be stretching our soleus. So if you're familiar at all with like the typical kind of wall stretch, our photo here, standing, the far right photo, far right photo, she is keeping her back leg straight, and that is stretching her gastrocnemius muscle. When she bends the knee, that will stretch the soleus muscle. So it doesn't require any different positioning, no different, just simply keeping one straight, keeping one bent. Same in the seated position, one is straight and one is bent. This gentleman is using a towel and pulling it towards him to get that ankle stretched, but you could also like put your foot inversion table, something at home, just like passively pressing your ankle against it, bent straight. So we are at close to 10 minutes. I have some more exercises. Happy to keep showing you photos of exercises and things that I think about for CMT patients, specifically related to like building core, hip range of motion, a little bit more on the hip extensors. I also want to allow time for questions, and this is kind of a good stopping point if anyone has any questions.
We're going to use the microphone because we're recording the sessions. So just give us 1 second, please.
His question was about reps and times to hold position. So stretching, I would say probably at least 20 seconds, if not 30 seconds, holding these positions. Probably a good idea to warm up the muscles before you stretch them. Could be a little bit of gentle walking or just, even like if you like moved your ankle passively, range of motion, warm up the muscle, kind of give it some warning that you're going to want to stretch it. It might go a little better. Muscles tend to do better in warmer settings. So like after a shower would be a good time to stretch too. The reps for strengthening, I would say it's individually preferenced. So if bearing in mind your neuromuscular precautions, so you're going to tailor it if it's too much, I would say about 10 reps, and then pausing in between each exercise, and 3 to 4 sets. But doing something is better than nothing, which is why I'm not writing it as like a prescription, like you must do this and this, because I think a lot of people feel like exercise has to be this formal structured thing. If I don't do all of the reps or all of the set, then it's not worth doing, that it's not worth pursuing, and like that mentality is not helping you. So we want you to do some movement, and if you do half the reps, half the sets, that's better than nothing.
Thank you, Dr. Schmidt. We have a question over here. Hang on for the microphone. And please hold it very close to your mouth because we are recording, and we want the recordings to turn out so we hear the question.
Hi. I don't use a gym myself. I just, go out walking with my walker every day. But I'm sort of thinking about it.
Yeah.
And my question is, does it make sense to use something like a leg press? And if so, would you recommend taking off your AFOs first? Would you derive more benefit from that?
That's a great question. So a leg press is going to work those proximal muscles. So I would say yes. I would wear your AFOs because your AFOs are going to hold your ankles in a nice neutral position, and then that will allow you to use your knee and your hip muscles better. Versus if you took the AFOs off and your ankles were allowed to go in whatever direction they wanted, you might actually be preventing your ability to use some of those muscles.
Laurel, over to Anna.
What I have is I've had a mess for the last 4 years, but when I go to exercise, you have to understand you do not feel the muscles being pulled. So you can stretch it too far quickly.
Yeah.
And you can hurt yourself immensely.
Yeah.
I have to have my feet tied to a bicycle thing just to be able to exercise. But remember, don't push it. When you hear a bone pop,
no, gosh, no.
You've gone too far.
Totally agree.
But that does not mean that your therapist doesn't understand that.
Yes.
They think that popping is not a bad thing. It's just something that happens because you don't feel it.
Right.
And they don't realize it. And then all of a sudden the next day you're going, I'm not getting up today.
And that's where a therapist can be really helpful because they see you. They can see a third party can see the position you're in, make sure you're using the muscle correctly. But like I was talking about neuromuscular precautions, I will educate my patients about them, what the goals are, what they're going to do, and then they're going to go on to their therapist. But it's super important. You and the therapist need to be in constant conversation about how you're feeling, if you need more rest breaks. I think the majority of therapists are really good about that, but every once in a while a patient will come back and they feel exhausted, frustrated, pushed way too far, and that's where I worry, I don't want to discourage someone from trying to exercise.
Thanks, Dr. Schmidt. In your summit bag is the PT-OT guide that was developed by the CMTA Advisory Board. Take that with you to your PT. That can be a wonderful educational resource for your PT and OT. We have a question right here.
It's on the website, too, as a PDF.
I support doing lots of exercises, and I've swam for years. But I find myself, as I'm over 70 now, with what seems to me more like a geriatric problem. And I easily overdo it. Mm-hmm. And I really have a hard time with swimming even. I'm in pain maybe the night after swimming and even the day after the day after. Uh-huh. So it's almost like anything I do is overdoing it. Can you give me any guidance?
So something
take care
like
of an old person.
I have a few thoughts. So I would try and incorporate more strength training, try to just strengthen some of these muscles that you're working while you're swimming. The other thing, swimming is not an easy exercise to build in more rest breaks, but often when patients say they feel they're getting more fatigued, we'll tell them to take more rest breaks, cut back the reps, do maybe one last set, or if they're using weights, use a lighter weight. Use anti-gravity, those kinds of things. I think fatigue in general is another big issue in CMT. Just people feel that overall draining feeling. And so maybe it's more about swimming. What else did you do that day, right? Are you fitting in, is a super active day and then you're swimming on top of that? Or is it a pretty sedentary day and swimming, and just kind of thinking about how you're expending your energy beyond just the exercise activity?
Anna, do you have one?
Yes, we have a few over here. Hi there. So I'm not sure how often you see hip dysplasia with CMT patients, but can you just comment on any precautions with hip dysplasia and the hip flexor exercises you've been mentioning?
I wouldn't say necessarily any precautions. If anything, doing those exercises might help the hip. So I see hip dysplasia I see adult patients, so it tends to be a lot of like hip pain, hip pathology when the hip dysplasia is bothersome and symptomatic. And those exercises are exactly what I want patients doing to try to help. What we're doing is we're trying to help strengthen the hip girdle in general to take pressure off of the hip joint itself and give it more stability.
Okay, and we have one last quick question over here. And then also, I know we haven't gotten to everyone's questions, but I think Dr. Schmidt will be here during the break. Okay, so be patient with us. Thank you.
Hi, Dr. Schmidt. I have 2 children, both whom have CMT, and at this point they're able to be pretty active. They've both been in baseball, and my one's just starting swimming. I guess my main question is, well, I'm curious about overheating. Is overheating something that happens commonly with CMT? And number 2,
I have not heard that before.
Okay.
So someone behind you feels really
I know
strongly.
that's been that's something that happens to their father who also has CMT. But also, like, how should I advise their coaches on, like when to let up, maybe, and how do I coach my kids on when to know their limits? Because I don't know that it's the same for all kids. It's hard to know.
Yep. I think it's just that. I think like you just give them the precaution of like they might need to let up. But at the same time, you don't want them to you want your kids to participate as much as they want to, right? Like that's like participation is all of it, right? It's the whole thing. And so moving and running, and you don't want to hold them, you don't want their coach to hold them back in some way. But at the same time, like if you're gassed and you're really tired, maybe you need a rest break. And I think teaching your kids to advocate for themselves is like such an important skill at a young age.
That was a great question. We are pretty much at time, so I want to thank Dr. Schmidt for being with us, and she'll be here during the break. Thank you, Dr. Schmidt.